So now we will launch the discussion panel in which we will approach together the opportunities to improve the treatment, HIV treatment cascade, to fill in those gaps and to overcome the barriers. And nobody else than Svetlana Plomadiala, country manager of UNAIDS, could moderate this discussion panel in the most efficient way, because Svetlana takes care of all the components. Also, the UNAID focus covers the technical support, and not only technical but material as well. And we always have the coordination on behalf of UNAIDS Moldova. We are very happy to have her here. Good evening, as Mrs. Popovich said, because it's closer to evening than to afternoon. Thank you so much to all those who had presentations. Now we try to have some a little bit more open discussion to understand which are the experiences of the countries, including the attempt to cover those gaps in the treatment. I am not sure if you understood in the morning from the presentation of Erin Murphy, but first of all, when we speak about the treatment cascade, Moldova has a very modest place in that rating, and actually it has one of the most modest results when we speak about the treatment cascade. I would like to invite here for discussions in order not to lose much time. I just want to moderate and not to take much of your time. And I would like to invite our panelists, who are Alina Kozhokar from Initiativa Pozitiva, Alexandru Goja from the Gender Docam NGO, Yuri Klimashevki, coordinator of the National Program Against HIV in Moldova. I would like to invite a good friend of the Republic of Moldova, Giedrius Likatavičius from Lithuania. We have online from Strong Minds, Charlotte Oloya. And also, I hope, I saw him in the morning, Mr. Andrei Shanu, please. Please take your seats. A little bit of gender balance here. We put Alina in the center. Okay, thank you. Is Charlotte online? Okay. So immediately we will move to the questions. So we will start with the community representatives. I somehow understand that we have classifications per two: non-governmental sector, and public sector of Moldova and of Lithuania, and then we have representatives of mental health area. And we will try to understand how this treatment cascade is related to mental health in the end. We will start with the community, and I would like to ask Alina to refer to the modality of involving the community, and to tell us which should be those interventions and especially results that the community could offer us in service provision. So how could the community impact the treatment cascade? And when we speak about Initiativa Pozitiva, it is not recognized only by the fact that it has a lot of innovations in its record, but it is known for many community services and their integration. Alina, please, you have the floor.
So probably you wanted to talk about an important aspect today. It's concerning it concerns decriminalization of HIV in Moldova. So hopefully in Moldova today, nobody discusses decriminalization, whether or not. But what's discussed rather is how to facilitate it, how to make it quicker. And so the question also is how to do it. And through numerous meetings, we used to ask this question. So how to do it, and whether everyone is free to do what they want. But what we say is that this decriminalization should be demonized, because there is a procedure, in fact. So if you find someone who doesn't do any harm, or actually who does harm to health or well-being of another person by not disclosing their HIV status, then they should be actually punished according to the criminal code, and we have a special article in the criminal code. So we actually support it, and everyone agrees that it's a good approach, correct approach. We have studied the documents, and our specialists say that there is a legal provision to charge guilty persons. We also have analyzed the experience of other countries where this mechanism is successfully applied. This is Switzerland, Germany, Portugal, Finland. Quite a lengthy list of countries which have already done it, implemented it. And so international trends mainly focus on a human rights approach and ensuring everyone an equal and non-discriminatory treatment. And urge people, motivate people to treat without fear. And of course, there are specific articles for the criminals. So people who do it consciously, they should be punished accordingly. So we started our process in 2022. The process of decriminalization of HIV. And over 60 persons actually were involved in various kinds of meetings with experts, with public institutions, and so on. So all stakeholders, and discussed what and how must be changed. So all these comments were collected and submitted to the parliament, which discussed them and accepted them approved them in the first reading. In the second reading, unfortunately, they were not approved because the Ministry of Justice required a more detailed information about it. So where we are now? Fortunately, the Ministry of Justice showed its openness, and we have recently had a meeting with the Ministry of Justice where we discuss what we lack and what we still need to present to move this whole process forward. So we have submitted the documents, and on this Wednesday, we are going to have a technical meeting with the Ministry of Justice to discuss technicalities of what needs to be done, what needs to be changed. So lawyers and specialists will be involved who will take care of this, that these changes be duly done. We are ready to contribute to planning and implementation of decriminalization as soon as possible. And we will thus present to the Parliament the ready package of what needs to be approved. So I want to emphasize that public institutions have shown their openness, and we are highly supported by all partners. And I would like to thank you all very much. So hopefully this year we will see this implemented.
Thank you so much, Alina. I somehow made a synthesis of what your initiative is doing and how it integrates the services, but thank you for touching on this important aspect of policies and restrictive laws. Mentioned by Stella as well in her presentation. And she has presented with evidence what is happening and how it is happening, and at what extent the restrictive policies and laws represent a barrier in accessing the services and in attaining the desired targets in the treatment cascade. Thank you so much, and we will return slowly to the community models of service provision. And I would like to ask Alexandro to tell us about the integrated service model at an organizational level and about the community represented by you, and which would be the benefits of this service model for the beneficiaries and for the treatment cascade. And please don't forget about the 5 minutes, because we have here the most loyal in the room, and we try to respect their time as well. Thank you. Thank you so much, everyone, for your presence. Dear audience, I will try to shortly and as complex as possible to tell you about the integrated services rendered at the Gender Document Information Center and by the other partner organizations, because lately the services for prevention and HIV fighting started to be integrated in more and more organizations working in this domain. And I think it would be good to start with a history of these services. The first services in Moldova were the distribution of protection materials, condoms and lubricants and syringes. And from here, step by step, we started the service diversification, taking into account the needs of beneficiaries from all the communities. So now at the Information Center Gender Document, we have community services, PrEP community service, because it was necessary to have this intervention. The service came closer to the beneficiaries. The first thing when you go to talk to a family doctor is like, I am testing the pregnant women. Thank you for that. But slowly, we have to find a common understanding, and I hope that gradually, with stigma, with fear of diagnostic, don't believe that only the patients or other persons are afraid of HIV. The medical workers are afraid of HIV as well. They are afraid of proposing a diagnostic. They are afraid of telling about a diagnostic when the result is here. Some people say, why do you talk so much about HIV? You didn't find the patient. But there is a lot of discussion on radio, on TV, about stigma, about discrimination, on any topic relating to HIV. This leads to the fact that people start to hear about this, and this become like something usual. And they don't have that fear like some 10 or 15 years ago. Thank you. I try to be as short as possible. That's it from my side. Thank you so much, Yuri. We have 2 frontliners here. And this civil society and very important, the family medicine, which is also very close to the citizens, to the people. And well, maybe this is what makes the medicine focus on the person, or the health focused on, person-focused health operational, when we have these chains involved. Thank you so much. And
Gedrus. So I said you are one of the best friends of Moldova, so you supported us in developing the actual national program, but also the national actual Global Fund grant. But now we are here today to ask you about the experience of Baltic states. So my question is, what are some of the good practices in every element of the treatment cascade that brought Baltic states to impactful results? And what are the main ingredients of success?
Thank you very much for this opportunity to be present here and exchange some experiences. Also, thanks for the audience to stay for so long. I would start probably from a bit of context of the treatment cascade. We have a country which is double size of Moldova. I will talk about Lithuania mainly. And as our cascade is quite similar to yours, at least the first and second part. So I would start from the third 95, which our current achievement is 95. So we actually have 95% of viral load suppression among those patients who are on treatment. And based on some on the disaggregated data by key populations, the highest, if we take into account the last 6 years, is among MSM, around 98%. And then we have heterosexuals, around 90%, and then people who inject drugs, 77%, which is the lowest with undetectable viral load. So why is that? We have some differences approach compared to your country. We have 5 IRT sites in the country, which is linked to infectious disease clinics in large cities with hospitals nearby and laboratories, which allows to have the follow-up, clinical follow-up. And basically country, we still feel it's not as big as it is, and looks like based on the patients' feedback, it's still we are somehow a bit jealous to see Svetlana's research she presented here about those 3 studies, how you can elaborate on different reasons why patients are dropping out or are late initiators. So we don't have this luxury as not so many funding opportunities are in the country. But nevertheless, these 5 treatment sites are giving us opportunity to provide differentiated approach for treatment, longer regimens, 3 up to 6 months in some cases. And COVID has taught us also possibility to have some remote consultations, let's say close to telemedicine, when our IRTs are normally distributed also through pharmacy. So we don't have clinics dealing with medication, distribution of medication, which reduces a bit the burden of the patient. So basically patient can call the doctor and prolong in case of if there is a reason and if there are some criteria of the mutual trust. What is also what we feel is important is the collaboration with other healthcare facilities. For example, the facility which I present here, Addiction Center, we sometimes also have patients with HIV, and patients are sometimes hospitalized and they don't have enough medication. So our doctor has a right to electronically prescribe, and then either patient or his relative can bring necessary medication so he can continue. There is no disruption. So there is this kind of, he can prolong, actually he cannot prescribe, but he can prolong the treatment. We also have quite important collaboration with non-governmental organizations, and especially during this start of active war activities, the war refugees have been really putting pressure to our health system. So we have really involved a lot of non-governmental organizations to help not only with RTs but with complex issues, social issues, and so on. Going to the second 95, which is 69 in our country, those people who are on RT, there were several legal barriers which have been removed. One of them was that before 2023 we had a referral from the general practitioner to have to go to the infectious disease doctor. So after that we have removed this requirement, and now patient, if he has preliminary HIV positive and then confirmatory can be arranged by NGO, he can go directly to infectious disease doctor. A green corridor, actually green corridor to infectious disease doctor, it was very important because these are dedicated days and times when a person can come or can be brought by, if there are some issues, by a non-governmental organization to have the first consultation, so he can be integrated. So the most problematic, we also have the first 95, which is 68 in our situation. So we have also differentiated testing approaches. We have provider-initiated testing. We have different also community testing, yes. And what is promising is self-testing. So we have done quite some pilot studies, and especially those individuals who are living more far away. So they were really bringing back even the results. So there was a response rate. Basically, they were not needed they have receiving the test box, self-test kits with some packages of information, and bringing their results back with photos and so on. So it was quite I think, promising, and this would increase the situation. In this meeting, it's the last moment mentioned that young people who were not injecting drug users but psychoactive substances users. So our quite also frequently used method in festivals and different bars and discos, we used to have not only HIV testing but also drug checking activity, and that attracts people, and they could be not only tested but also change their drug using behaviors. So with this, I just will not continue.
We are going to Charlotte, and thank you so much that you are here. So we made close Moldova and Uganda. Yeah, so we have a question to you. I don't know what time is it there in Uganda. It's about 6 p.m. here in Moldova. So Charlotte, why is mental health of people we serve important in the assurance of an efficient treatment cascade, and how can it be integrated into the HIV response? Strong Minds. So Charlotte is from Strong Minds organization. Where is she? Am pierdut-o.
Thank you very much. Yes, thank you very much. It is also about 6 p.m. In Uganda, about 5 minutes to 7. So I guess the time is a little bit the same between Uganda and Moldova. I'm definitely excited to be speaking to all of you. As Strong Minds, for those that may not know, and for those that I cannot see in the room, I can only really see the panelists. Strong Minds is a social enterprise, and we treat mental health, and we treat depression, and we use interpersonal psychotherapy for group, which is a WHO approved model for treatment of depression and anxiety in low resource settings. We started the model in Uganda in about 10 years ago, and have expanded that across Africa, integrating it in different sectors. And when we started out, I'm just giving you a brief background. I'm aware of the 5 minutes. When we started out, we did start with treating mental health directly. But over the past couple of years, what we've seen is that it is very important to integrate the treatment of mental health across sectors. And what better sector to start with than HIV? We definitely know that when we talk about when we talk about the treatment cascade, that each stage of the treatment cascade depends not only on medical interventions, but also on psychological and the emotional well-being of individuals, and that poor mental health is a barrier at every stage of the treatment cascade. And so we know that addressing these mental health challenges is key to improving efficiency and effectiveness in HIV care. I said we do IPTG, we do it in groups in the community, and we've been very fortunate that earlier this year we started a project called the USAID Mental Health Integration Activity. And what we this came out of a proof of concept that we'd done with another HIV organization. This organization had found that when people in the first 95, when we were talking about HIV testing, the stigma and fear that is associated with testing actually delayed or impeded the ability of people to go and actually test for HIV. So what they did was introduce therapy in that first 95, and this is group therapy. I'm getting a bit feedback. I don't know if it's yeah, I don't know if there's something I'm not doing, but I'm hearing feed myself on this other side. But yes, so they introduced this organization that is called Mukobadi. We partnered with them to integrate mental health into their HIV programming. And what they found is that when they integrated it, the testing, the number of people that actually started to go for testing went up, because we're taking care not only of their physical health, but also of their psychological well-being. If we talk about mental health and the linkage to care and starting early treatment, we found that, once diagnosed, mental health conditions such as depression and anxiety actually reduced people's motivation to seek care and start early antiretroviral treatment. So people, they felt hopeless. And when we talk about the signs and symptoms, maybe of depression or anxiety, and we look at 9 generalized signs and symptoms, and one of them is a feeling of hopelessness, a feeling of unworthiness. And this, they found that is something that affects the orphans and vulnerable children that they were working with in the eastern part of Uganda. But they found that when they integrated mental health treatment for depression into that stage of the 95, then the number of people that actually went for started early treatment also went up. If we talk about mental health and retention in care, for those that are in the field of mental health, they will know that depression and mental health conditions are a very significant barrier to retention in terms of HIV care. Persons living with HIV, adolescents and children living with HIV who are not mentally well may miss appointments. They will interrupt treatment. They will disengage from care. They will feel too despondent to follow up with the treatment. And so because people with untreated mental health conditions, people with untreated depression, may face barriers such as low energy, hopelessness. They want to isolate. These are signs and symptoms of depression. And so that when they face those issues, then they are going to interrupt care. But what we found is that when we integrate the health service delivery into HIV settings, providing on-site counseling, but more than that, because the Strong Minds model is actually group therapy, and the group therapy is homogeneous. So it's people whose trigger, for example, is isolation. I am feeling isolated. I'm grieving this test result that I have received. There's a life change that I'm going through. All these things, these 4 triggers that we look at. When we found that when they sit together in groups and they sit together and they listen to one another, there is then a support system that is around them that will support them even to stay engaged and not interrupt treatment. If we talk about mental health and adherence, just ensuring consistency. Ensuring consistency. Clients. People with mental health issues will probably have poor adherence and may lack the motivation and energy and mental clarity to remember to take their medication daily. So what have we done? We train community health workers. We train expert HIV clients. We train teacher facilitators. We train youth champions to be able to deliver therapy within the community, so that when adolescents are facing, are feeling isolated or are feeling despondent, they don't want to move, there is somebody within the community that will actually be able to deliver therapy to them. But also they have a support group that is around them. Their peers that are around them that would be able to support them. We see how addressing this, how does it improve efficiency in the treatment cascade? We see improvement in HIV services. We see less interruption of treatment, and we actually have the results to show that when we've integrated mental health into HIV care for partners and not thought about mental health as a silo, but integrated it and ensured that it's community based, not only at the facility, but actually in the community where the people live, where there is stigma, where there are questions, where they self-isolate. And then in those situations, we see that there's improved there's a contribution to improved adherence. There's a contribution to not interrupting treatment. There's more confidence. But also lastly, as I conclude, is that we do not forget the caregiver. So while we are taking care of the mental health of the person living with HIV or the adolescent or the child living with HIV, we do not forget the caregiver, because the caregiver is an enabler to this person to remember to take their medication, to remember to go back to the facility and fill up on the drugs, to remember to eat healthy. We do not forget the caregiver. And so even in the community, while we integrate with this service, we provide a whole community approach that even the caregiver is targeted for therapy, but the community at large as well is targeted for awareness about mental health, so that we are destigmatizing both mental health and HIV. Yeah.
Thank you.
Yeah.
Thank you. Thank you, Charlotte, for being so passionate about what you are doing. And thank you for having our people that we serve at center, but also the caregivers. And I am thinking also about the health staff and thinking about Moldova and the crisis we go through, starting with COVID and the war in Ukraine. I know for sure that there is a huge burden on them too. Thank you a lot for these thoughtful ideas, and we continue on the same with the mental health, and we have here Andrei Iașanu. He is a Moldovan și pot să trec și la română, așa? Mulțumesc.
Switch to Romanian. He is a psychiatrist and a psychotherapist, the assistant professor at Pharmaceutics and Medicine University from Moldova. I have a question to you. If you could in 5 minutes tell us about the Moldovan experience and the approaches in mental health. And the question is how to consolidate the national response. Thank you. Thank you so much. Good evening to everyone. Once again, congratulations on your courage to stay until such a late time. I'm also happy to listen to Mrs. Charlotte from Uganda. I have the impression that I would like to also go there to learn based on the Uganda experience. Definitely. Every aspect mentioned by you is worth highlighting several times. And I will start with the following. Mental health is a transversal issue. And I'm so happy that mental health is being discussed. Also, when it comes to the treatment of people living with HIV in the Republic of Moldova, we have reforms in the field of mental health, and we develop community centers for mental health. And today I was so happy to listen several times about mental health, including about youth-friendly health centers. I also heard about psychological support, and not only provided to youth. And I think these are important moments to develop the mental health system. With all that, there are so many gaps to cover, and we have to mention primary health care. Now we are in the process of developing research. Actually, we already have some preliminary data, and we have to see what's the diagnosis of depression and anxiety in primary health care. We have our clinical protocols for Moldova. So the family doctor has to include this into the treatment of people with depression, but we also face high level of stigmatization also when it comes to mental health. And speaking about people living with HIV, we have double, triple, quadruple stigmatization, and many times there are people living with HIV, and if they have mental health issues, they add up one more issue of stigmatization, especially if besides that they consume drugs. Again, the stigmatization level increases. People living with HIV have the risk of developing anxiety and depression at least twice more often compared to the general population, and this is quite a huge number. WHO says that we have about 4% of people with depression all over the world. And if we report this to the general population, this is a huge number. In Moldova, preliminary data shows that we have people with the severe depression, and in our research, the data says that this is more than 8%. Again, this is preliminary data, and it is already double compared to the average provided by the WHO. The official data in the Republic of Moldova say the following. I wonder whether you know actually how many people with depression we had. In 2022, we had 1,800 people. This is 0.07% actually, officially. And the gap between the diagnosis and not covering the treatment is huge, I would say. I think that there is a number of reasons for this gap. First, abilities have to be present to establish a diagnosis, and again we have a huge level of stigmatization. Our society shows that more than 50% of family doctors consider that depression is not a real disease. They think that depression is just social weakness or a caprice. And definitely having such data, it's difficult to imagine that people would ever be diagnosed with depression. Again, there is self-stigmatization. Patients that come to family doctors, more than 60% of them consider that depression is not a real disease. And since it's not a real disease, why should I consult a doctor? Why should I ask for assistance? We do not have specific researches for people living with HIV in this regard, but I guess that we would have not so nice data as well. Just imagine that a person living with HIV would say, I know I have HIV, it's okay that I go through sadness, through desperation. This is not a depression, this is my social situation and status. Then why should I ask for support? This high level of stigmatization shows that we have a lot to work in this regard. And the integrated services, social medical services, are a great solution, and I think that we can provide both medical and social support, and also mental health support. And I hope that there will be more cooperation with community centers for mental health that are present in all the districts. And that they are available for people living with HIV. But we need more cooperation between various fields. By this, they have to learn with each other. They have to learn to work with each other. And the community with mental deviations, they have to learn to work with the system of peer-to-peer, and in 2024 we have a law that introduced the notion of peer-to-peer in mental health, and I would like to thank to the community of people living with HIV, because we have best practices of peer-to-peer cases when people having severe mental disorders learned to cooperate. Again, we have to work in the sphere of merging or joining psychiatry services and drug user services. People who consume drugs, they are in the risk group, they need a more complex approach. We have inherited from the Soviet Union the two separate systems, and we have to work a lot to merge them or to teach them how to better cooperate, and the way it happens in developed countries. Briefly, I think these are the key aspects I wanted to highlight. Of course, we have a lot to work, but I'm happy that mental health is being discussed transversally and within this conference as well. So I'm more than open to answer to any of your questions, and I'm ready to continue discussions. Thank you. Thank you, Andrei. As we say, equity should be kept during all sessions. So if there is any question, please do not stay shy, just ask questions. I understand that we are in delay. Is there a question? Oh yes, please. Svetlana, the floor is yours. Just help me, someone with the microphone. Hello, everyone. I would like to thank the organizers, and I would like to thank all the participants. I wanted to speak with my voice without the microphone, but I see it doesn't work. I would like to thank all the participants, all the organizers. Definitely a lot of aspects were covered, and definitely it's important to know how to discuss, how to find solutions. I have a question to Mr. Klimashevsky. Dear Yuri, what would you say? ARV treatment should be delivered based on e-receipt via pharmacies or not? I refer to Moldova, of course. And would this change the situation or not? Well, prescription by receipt is more than realistic, but in the end, not many medications that we have can be distributed in all the pharmacies in Moldova. In the end, there will be, nevertheless, a pharmacy next to a polyclinic that will issue this medication. We've discussed this issue many times. The patients say, okay, I will come to the doctor. They will give me the drugs and I'm happy. But in the pharmacy, the pharmacist will see me, then the cleaning lady will see me, and the same goes with other drugs, medications. Everyone knows what a specific medication is for. I know that in Western European countries, there is medication available in pharmacies only. No family doctor, no medical assistant issues these medications. There is no such a system present. And if there is a request that, for instance, in Cahul, people would prefer to get the medication in pharmacies, okay, but in the end, the patient will go to the doctor nevertheless, and now only digital receipts are being prescribed. I also have 2 chronic diseases, and I also receive them using electronic recipes. Let's discuss it. I am not categorically against. If the patient thinks that this is a better approach, why not? Are you happy with my answer? Yes, thank you. Then I think it's worth staying at the first level to provide society information, to raise the awareness. And we have to understand that there is this issue present, and the attitude of the society has to be changed. Thank you. Thank you. Are there any other questions? We can take one more question. I don't see more questions, but I would like to give a round of applause to today's panelists and to you, of course. This is the very last session. Thank you so much for having stayed alive. And one more minute of announcements, and we come to closing. Charlotte, if you're still with us online, thank you so much again.